Hi, good afternoon to our Kaweah Health community engagement groups. Thank you for tuning in today. It's been a while since we last gathered, and I appreciate all of you taking a little bit of time out of your busy days to join us and find out some of the goings on here at Kaweah Health. I'm in the Kaweah Health studio, joined by Daniel, Maria, and Kelsey. My usual partner in crime, Deborah Volison, I understand, just became a grandmother. So she's not joining us today. So they're kind of leaving me a bit on my own here. But we are also changing up the format a bit. So I do have a number of questions that have been posed to me, and then a few others that just came in, I guess, earlier this morning that I'll try to address as well. But then certainly invite, although do we have a way for people to call in or chat in? Or
Yeah.
Oh, we do. Okay, so also just something comes to mind during the middle of this broadcast, a new question that you want to ask or maybe clarification on a particular question, be happy to answer that as well. So, all right, so we'll get started, and these are some great questions. I really appreciate them. This first one, can you explain what a hospital is and why we contract with hospitalist groups? So once again, it prompted a little bit of research on my part. I'm very, very familiar with hospitalists and hospitalist groups, but I was not aware that it was back in 1996 that Dr. Robert Wachter and Lee Goldman first coined the term hospitalist in the New England Journal of Medicine. And essentially, they defined it as a physician that their sole focus is on taking care of patients that are hospitalized. So prior to the advent of hospitalists, it was quite common that your personal physician, that might be a family medicine physician, maybe an internal medicine physician, a pediatrician, an obstetrician. It was kind of the norm that you would go to them to see them in their office, but if you needed to be hospitalized, they would also be the physician that would take care of you while you're in the hospital. And oftentimes, they'd first spend their day seeing all their patients in their office, and then at the end of the day, they would go over to the hospital and round on their patients that were in the hospital. But that became increasingly difficult for physicians, particularly if they had to run over in the middle of the day to see a patient in the hospital. You can imagine how that would disrupt their office practice, where they may have already had a full waiting room of people that now had to wait or have their appointments canceled and rescheduled. So at the really the encouragement and with the blessing of the general medical physician community, they began to ask hospitals to create these hospitalist programs where the hospital would contract with generally a group of physicians who, again, were generally family medicine physicians or internal medicine physicians, that the hospital would contract formally with the medical group, and that those physicians would spend all their time in the hospital, and they would just be taking care of patients that were hospitalized. They did stay in close communication and contact with your primary care physician, so keeping them informed throughout your stay, sharing your medical record with them, excuse me, discharge instructions, things of that nature, particularly if your primary care physician wanted to have a follow-up appointment with you after you were discharged. So it has become very, very commonplace now for hospitals to not employ. California hospitals are prohibited from actually employing doctors, but we contract then with a medical group to provide that hospitalist care, which then allows your community physician, your primary care physician, to be more available to their patients out in the outpatient setting. So Kaweah Health contracts with a hospitalist group by the name of the Valley Hospitalist Group, It's owned locally by 3 physicians, Dr. Anzi Saeed, Dr. Gurtej Dillon, and Dr. Chaki Gurgis. And so they are the principal owners of the Valley Hospice Group. They then contract with probably more than 20 physicians, again, family medicine, internal medicine. They generally work 7 days on, 12-hour shifts, and then they have 7 days off. We try to keep them kind of in the same place throughout the hospital, whether they're always on 4 North or 4 South, so that they become very familiar with that unit. They develop relationships with the staff, so just kind of provides that continuity of care. The fact that they work 7 days on too. Our patients generally stay on average about 5.5 days at the hospital. So ideally, you have the same hospitalist that's managing you throughout your entire stay. In addition, Family Healthcare Network, they employ hospitalists. So when a Family Healthcare Network patient needs to be hospitalized, Family Healthcare Network has physicians that are stationed in the hospital that take care of their patients while they're hospitalized. Similarly, Key Medical Group, which is the physician group that contracts with Humana for the Medicare Advantage members. So if a Humana Medicare Advantage member needs to be hospitalized at Kaweah, then a Key Medical Group hospitalist will take care of that patient while they're in the hospital. So in any event, it's a great program. We've been contracted with the Valley Hospice Group for many, many, many years. Greatly appreciate their good work and our relationship with them and the leadership of Dr. Dillon and Saeed and Gurgis. So thank you for that question. In a similar vein, with respect to contracted physicians, the question was, we recently changed our ICU, CVICU, which is cardiac ICU, physician contract and are moving to sound physicians. Can you explain why that decision was made and what made you choose sound physicians? So again, like the adult hospitalists, it's quite common that hospitals contract with a single medical group to provide physician services, in this case, critical care physician services, to patients that are admitted into the intensive care unit. So Kaweah has 2 ICUs, a 21-bed medical ICU and a 20-bed cardiovascular ICU. And then we also have 2 intermediate critical care units. So our 30-bed ICCU on 3 West, and then our 24-bed ICCU on 5 Tower, which is the Asequia Wing Tower. So we currently contract with a medical group, Central Valley Critical Care Medical Group, that is similarly locally owned by 2 physicians, Dr. Joe Malley and Dr. Vishnu Bezwada. So we have been contracted with the Central Valley Critical Care Medical Group for the last 9 years to provide those professional services. And while, again, similar to the hospice group, while it's owned by these 2 physicians, they then contract with numerous intensivists, critical care intensivists, as well as also adult hospitalists and nurse practitioners that together make up their workforce to staff those 4 units. So in today's healthcare environment, it is becoming increasingly difficult and challenging for small independent medical groups to be able to provide those contracted physician services. It's a very, very competitive environment out there to be able to recruit and retain physicians across a lot of different specialties. And the critical care medical group, our Central Valley group, is certainly not immune to those competitive factors. And as a result, they've also struggled to be able to consistently staff those units and be able to attract and keep physicians who are constantly being courted by many other medical groups across the country to come work for them. So many of our physicians, in fact, that work for Central Valley Critical Care are not from the local community. They live in other communities but come to Visalia to do their shifts. At the same time, it also, from an economic standpoint, is very hard for independent groups. They definitely don't enjoy the economic advantages that a large group like Sound Physicians does, who has multiple sites across the country and is able to kind of spread those administrative and overhead costs out over a broader base. So a lot more expensive to operate a local medical group, which comes at a greater expense to us as well, because most all of those contracted medical groups, Kaweah has to provide funding to them in addition to the professional fees that they bill and collect and keep. Unfortunately, because of the socioeconomic makeup of our community, as you've heard me say many, many times, we have the highest Medi-Cal enrollment in the entire state, with more than 60% of our residents covered by Medi-Cal. And like hospitals, physicians receive very poor reimbursement from the state for taking care of Medi-Cal patients. And so we spend more than $90 million a year that comes out of our hospital revenues to provide financial support to these groups. And so smaller groups require a much larger financial support from Kaweah, who we're under, obviously incredible pressure to continue to become a more cost-effective organization for our own survival. Our emergency medicine group is Vituity, which is a very, very large emergency medicine company that staffs numerous EDs up and down the West Coast. And by being that very large organization, they also are able to provide their services at a lower cost to us than maybe if we were contracted with a local single standalone medical group. And so over the last several months, over the summer, myself and a number of our hospital leaders were meeting closely with Dr. Malley and Dr. Bezwada. How do we address this? And I think after some very thoughtful, careful consideration, we both came to the conclusion that it's been a great relationship. I greatly appreciate and value everything that Dr. Malley and Bezwada have brought to the hospital and their dedication and their commitment. But we agreed it was time to probably move in that different direction with a larger group. And so we initiated a formal request for proposal process. We sent out numerous RFPs to various groups, medical groups across the country. I believe we had 3 critical care intensivist groups that submitted formal proposals. We interviewed all those groups. We did reference checks, and we unanimously concluded that Sound Physicians would be the best fit for Kaweah, and came with an excellent reputation. I'll look at my notes a little bit here just to describe, but Sound Physicians got its start back in 2001 up in the Northwest, Pacific Northwest. They were founded by Dr. Robert Bessler. Sound Physicians is probably one of the most successful multi-specialty medical groups in the United States. They have more than 4,000 physicians and advanced practice providers, CRNAs, and nurses that are employed and work with Sound Physicians. They have an extraordinarily high net promoter score, which is when we survey our patients after discharge, they're asked a question: would you recommend this hospital to a friend or family? That's the net promoter score. And they have one of the highest in the nation across the various sites that they staff. They also regularly outperform other hospitalists and critical care groups in terms of length of stay, their acuity, management of their acuity. They partner with more than 400 hospitals across the U.S. And with respect to critical care, they have more than 100 hospitals that they are the physician group for that hospital's critical care service. In 2022, they cared for more than 125,000 ICU patients across their delivery system. And so again, with a group like that, they're able to develop uniform best practices and implement those. They have a very deep bench, and it's a lot easier to recruit physicians into a much larger group. So when you're recruiting a new intensivist out of fellowship, out of residency, they want that stability, and a larger group is able, because they have the financial resources and have multiple practice sites across the country. They're just much more attractive. It's why Kaiser is increasingly becoming an attractive place for physicians to want to work for. So we've also, their reference checks, as we contacted other CEOs and chief nursing officers, they had nothing but very positive things to say about their relationship with their Sound physicians. Their model is very similar to what Dr. Bezwada and Malley have. So they will likely, in fact, they've already been reaching out to the vast majority of our existing intensivists and hospitalists, those that work for Central Valley Critical Care Medical Group, to offer them positions within Sound Physicians. So I think I mistakenly heard that there was a belief that if we contracted with Sound, they bring in all these unknown physicians that are not part of our community, and that is not their model. The vast majority of the physicians come to work for Sound in a very similar arrangement. They are currently independent contractors to Dr. Malley and Bezwada's group, and they become independent contractors to Sound. They are also likely to receive a higher compensation from Sound because of, again, the economic advantages that Sound has. And then ultimately, many of these physicians are offered employment where they're receiving both compensation and benefits, again, as a large physician group able to procure health and dental and vision and other benefits at lower cost because they represent so many physicians. But if our physicians want to stay in an independent contractor arrangement, then they offer that as well. So I greatly appreciate the support that Dr. Bezwada and Dr. Malley have provided us. They're already working with Sound physicians to begin the transition. Very hopeful that Dr. Malley, who's already, he himself, has indicated that he wants to continue to stay and practice in this community. He loves critical care, and I've already reached out to Sound to make contact with him to offer employment or independent contractor to Dr. Malley as well. So we hope it to be a very seamless but very positive transition to them. It will probably take about 6 months before everything is firmly in place, but you'll continue to see the same physicians that have been taking care of you and your family members here at Kaweah Health. Okay, next question. Seismic updates are still lingering over the hospital, and the deadline is 2030. That may seem far off, but when one takes into account the amount of work and time associated with constructing a new hospital, that time frame is not very long. Also, can you explain what Senate Bill 525 is and the effect it can have on Kaweah Health if it passes? Again, two outstanding questions. I couldn't agree with you more that time is flying by. We are almost at the end of 2023, and January 1st, 2030 is just around the corner. Unfortunately, despite the tremendous efforts by Kaweah Health, by the California Hospital Association and the District Hospital Leadership Forum, despite all of our advocacy efforts, which continue to this day, Senate Bill 1953 is still intact and unchanged from its original structure. So our 206-bed Mineral King Wing which when you think of 2 south and 2 north, 3 south, 3 north, 4 south, 4 north, those 206 acute medical surgical beds that are in the original 1969 Mineral King Wing, they do not meet the seismic requirements of Senate Bill 1953, and as such cannot be used for acute inpatient care past January 1st, 2030. It is not possible to retrofit those beds, so we need to replace those beds. Many of you have been involved in our planning for a replacement tower that would be roughly a 10, possibly 11-story tower that would be built immediately to the west in front of the Kaweah Wing Tower, and would house roughly 240 new acute medical surgical beds, as well as additional critical care beds, surgical suites, a new PACU, new pharmacy, dietary, cafeteria, at a cost of $730 million. Well, in I guess one of the silver linings of the pandemic and its aftermath, and unfortunately the devastating financial impact that it's had on the California hospital industry, it did cause the legislature maybe to rethink Senate Bill 1953 and the ability of California hospitals to meet those requirements. More than 40% of California hospitals currently do not meet the seismic standards and either have to retrofit or rebuild by 2030. But there was an Assembly Bill 869 by Assembly Member Wood, who resides in Healdsburg, California. He put forth a bill that would provide a 5-year extension to kind of smaller, more independent, rural, non-urban hospitals, as well as all district hospitals. That would give us that 5-year extension, but also would indefinitely suspend the application of Senate Bill 1953 if those eligible hospitals could demonstrate that they were financially distressed and unable to raise the funding on their own to fund that replacement or that retrofit. And as long as you could demonstrate that you were not in the financial condition to do so, then you could continue to use your non-seismically compliant space until such time as the state of California provided the funding to fund that retrofit or that rebuilding. Unfortunately, while that bill passed the Assembly on a vote of 80-0, it then went to various Senate committees. And at some point, the author of that bill halted the deliberations on it. And we don't know the exact reasons. We believe it had to do with some administrative negotiations that were taking place between the legislators, the authors of the bill and the co-authors, and HCI, formerly OSHPD. HCI is who oversees and enforces and monitors all hospital-related building. So that bill has now been put into the category of what they call a 2-year bill, which is it's better than the bill being dead. So we certainly love the momentum. There was no opposition by any of the unions, which CHA's efforts to alter SB 1953 have always come up against union opposition. Who sees tremendous construction projects and higher union dues and lots of work for union-based employees, workers. This had no opposition whatsoever. But for the reasons known and unknown, the bill has now been kind of put in suspense, and it will be taken up again in the next legislative session that actually this legislative session just ended on September 14th. I was sharing with our board last night that there were more than 2,600 bills that were put forth by various lawmakers, state lawmakers, this last year over that 7-month legislative session. 900 of those bills made it to the governor's desk, and hundreds and hundreds of bills are sitting on his desk waiting for either his signature or his veto, which he has to do by October 14th. One of those bills that's sitting on his desk is Senate Bill 525, which has now passed the entire California legislature. So it's gone to Governor Newsom to sign into law or to veto. Now, certainly the legislature could override the governor's veto, but that rarely happens because there is dissent within the legislature, although it largely split along party lines. So this bill would provide for a new minimum wage for all healthcare workers in the state of California. And it would apply to hospitals, ambulatory surgery centers, whether they be hospital owned and operated or physician owned and operated or a combination. It would apply to skilled nursing facilities, mental health hospitals, rehabilitation hospitals, assisted living facilities, clinics, and even physician groups who have 25 or more physicians. And originally the bill, in its original form, would require that effective June 1, 2024, the minimum wage would go to $25 an hour for all healthcare workers, including those that the hospital contracts with. So if we contracted with a messenger service to come pick up labs, or contracted with a dietary company or a laundry company or something like that, they would also have to be guaranteed that minimum $25 wage. Well, through the, I'll say, efforts of the California Hospital Association and other stakeholders, they negotiated some relief from that original bill. And so in its final form, it has now been kind of segmented, particularly with respect to hospitals. So the big healthcare systems, and there are about 12 of them, so Kaiser, Adventist Health, Dignity, Sutter, Scripps, Sharps, the University of California system, did I say Adventist Health? All of them are required to increase their minimum wage to $23 effective June 1st, 24. That will go to $24 1 year later on June 1st, 2025, and then to $25 an hour on June 1st, 2026. After that, it will increase every year by the lower of the CPI, the Consumer Price Index, or 3.5%, whichever is lower. And there is no limit to how high it can go. So one of, I guess, the important concessions that was made is to recognize that hospitals like Kaweah and other standalone hospitals or hospitals of smaller health systems that have probably been impacted more severely by the pandemic. As I've shared with you, Kaufman Hall recently published a piece indicating that more than 50% of all California hospitals are operating deeply in the red. You've seen many hospitals declare bankruptcy, many services have been closed, and we are far from being out of the woods. And so to raise the minimum wage immediately to 23, 24, 25 would have a disastrous effect on those hospitals. So there are more than 40 hospitals that fall into this different bucket, Kaweah being one of them. Effective June 1, 24, we have to raise our minimum wage to $18 an hour. That will then rise by 3.5% a year So not the lesser of CPI or 3.5, but every year it will go up by 3.5% until it reaches that $25 an hour rate by June 1st, 2034. Is when it's projected to reach 25, and then it will go up after that, again, that lesser of CPI or 3.5%. So the bill is projected to cost the California hospital industry $8 billion in new costs in this first year, without a single penny of additional reimbursement from the state, which is really interesting that it's the same organization that provides, a significant amount of funding and reimbursement to hospitals for providing the care. It's also the very same entity that gets to tell you how much to pay for your cost of care. So I can't think of a greater conflict of interest than when you control both sides of the purse string, the revenue that comes in and the expense that goes out. But this is, again, one of the many unfunded California mandates that plagued the hospital industry for decades. So for Kaweah Health, it's interesting. While I think the legislature feels like it made some significant concessions for hospitals like Kaweah by only requiring that we go to $18 on June 1st. What they failed to realize is that Kaweah Health is surrounded by Adventist Health hospitals in Tulare, in Tehachapi, in Delano, in Bakersfield, and Hanford, and Selma, and Reedley, and all of those Adventist Health hospitals will be required to increase their minimum wage to that $23 an hour effective June 1, 24. Well, if Kaweah Health expects to retain or recruit any of its staff, they're definitely going to jump, they're going to jump to those hospitals if the minimum here is 18 and they can get $5 more an hour. If I'm a housekeeper or a dietary worker or administrative employee, $5 an hour means a lot. And I'm going to take that job. And it's a very competitive environment out there. So Kaweah will have no choice but to also raise our minimum wage to $23 an hour and to raise it the same as Adventist and Kaiser will have. Kaiser, just in Fresno, will have to do the same. So we're projecting that raising our wage rate to $23 an hour will have an immediate impact of about $13 million a year, and by the time we get to that 25, that annual impact will have increased to about $25 million a year. Because it's not just increasing the minimum pay rate, but it's also the payroll taxes, FICA that is based on a percentage, Medicare tax that's based on a percentage of your wages. You also now start having compression where you've increased the wage rate of an employee who's now making exactly the same amount as their supervisor. That's called compression, and that will require that we increase the pay rate of that supervisor even higher. And then there also is a requirement in labor law that to be a salaried exempt employee, that you have to make at least 2 times the minimum wage, the lowest wage in your hospital. So if I have a director or a manager that's currently making 2 times, the wage rate, and right now the statewide minimum wage is $15.50. It goes to $16 on January 1st, 2024. Yes. So if the minimum wage, when it gets to $25 an hour, will mean that to be exempt and not have to clock in and out and be subject to overtime and so forth, that exempt employee will have to make at least $50 an hour or more. So it's going to be really interesting to see what hospitals do if they decide more of their employees that are currently exempt, that they'll now make non-exempt and require them to clock in and clock out and be eligible to receive overtime. What's also interesting is the California Chamber of Commerce also came out strongly opposed to this bill, because imagine what it's going to do to other industries across California and in our own community. So employees that work for restaurants, waiters and waitresses and cooks, or housekeepers in a hotel or some other establishment, or you're in retail, you're a salesperson, and now I can go to work for a hospital pretty much doing the same job I'm doing now, but now I'm going to get paid a much higher rate. So that is going to have a profound effect on so many other industries here in our community that are also going to be forced to raise their rates to be competitive with hospitals and other healthcare entities, which could put some of them out of business, or for those that can pass that cost on to us as consumers, it will just mean higher prices for us. Another bill that's sitting on the governor's desk is pretty much the same thing for fast food workers. So their minimum hourly rate will go to $20 an hour effective January 1st, 24. So if the governor signs that bill, that also is going to have a huge impact on our local community and certainly the price of food. So that's, I'm the first to say I didn't think there was any chance possible that this bill could pass, 525 could pass in the current environment. We were the fortunate recipient of one of the Distressed Hospital Loan Program awards. So Kaweah soon will receive close to $21 million as an interest-free loan from the state, recognizing the distressed condition that we've been fighting through because of the pandemic. So that celebration is certainly short-lived at this point, because every single one of those distressed hospitals, there were 17 of them that qualified that will receive $300 million this year. All of us are subject to now that new wage structure. So, and this is a loan that has to be paid back, so it's not a grant. So thank you for that question. How am I doing okay on time? So August financials. I do have a few other questions I'll get to, but if I was to end on this one, I'd be ending on a happy note, which seems appropriate now. But our August financials have been released, and the question, can you share those with the group? And absolutely. So for the month of August, we generated $72 million in operating revenue, primarily patient care revenue, so taking care of patients, and what we bill and receive from Medicare, Medi-Cal, Anthem Blue Cross. That's the vast majority of our revenue comes from taking care of patients. But we also operate the Lifestyle Center and a cafeteria and a retail pharmacy, and so we do have revenue that comes in from other sources, but the vast majority comes from taking care of patients. And for the first time in I don't know how many months, we actually finished the month in the black. So we had a positive operating margin, and that means total revenue, that's $72 million that we collected in revenue, minus all of the expenses for our staff, benefits, physicians, supplies, food, energy, everything that goes into taking care of patients and running this organization. There was $48,000 that was left over. Now that's not much, and in years past we probably would have been very disappointed in that level of income, but obviously what we've lived through the last 3.5 years changes your perspective quite significantly. But to put that in perspective, why we're in such a celebratory mood, that $48,000 is $3.1 million better than what we had budgeted. And more importantly, it's $7.5 million better than what we experienced last August. So last year, we incurred a loss of almost $8 million in that single month. And to go from last year's August of almost an $8 million loss to this year's August of $48,000 profit is absolutely reason to celebrate. Probably the single biggest reason is we've now gone from paying $7 to $8 million a month in traveler nurses and contract labor to less than $2 million a month. So we've done a tremendous job weaning ourselves off of traveler nurses. We're still hovering about 80 traveler nurses right now, but far less than the 240 we had last September. And the hourly rate that we're paying to the contract agency is down to about $105 an hour instead of over $200 an hour, again, that we were paying back last September. But on top of that, we are also waiting to hear from the Federal Emergency Management Agency, or FEMA. We have a FEMA claim, a disaster claim, in front of them that's for about $19 million. So hospitals, because the federal government declared COVID as a national emergency, we were able to treat COVID as if it was like a hurricane or an earthquake or other natural disasters that FEMA generally steps in and provides logistical support as well as financial funding to help that community, that area get back on its feet. So many hospitals across the country have been filing these FEMA claims. We actually have already filed 4. The first 3, which were much, much smaller, have already been approved, but we're waiting on this 4th one. But we are very confident that it is going to be approved. It's definitely out of FEMA's comfort zone. It's not their typical disaster that they deal with, so they're just trying to sort through understanding, having us demonstrate to them these significant costs that we incurred that we wouldn't have incurred if not because of COVID. So directly related to the emergency. So we have actually budgeted that $19 million as part of our bottom line net income for this current year that we're now 2 months past. And so we are accruing 1/12 of that amount, or $1.6 million as income every month. So if you were to count that 1.6 million as well and add it to that 48,000, we would have an operating margin of 1.7 million. So right now we're just accruing it because it hasn't been approved and hasn't been funded, but we remain very optimistic that we will receive it. So now 2 months into the fiscal year, that started on July 1st, we have a positive, I'll say adjusted operating margin, meaning after counting those FEMA funds, 2/12 of it. We now have a positive operating margin of $256,000 and a bottom line net income. So after you add like investment earnings to it, the bottom line net income through the first 2 months is 1.5 million. Contrast that with a 14.2 million operating loss and a 13.4 million bottom line loss through the first 2 months of last year. So bottom line net loss last year, July and August, 13.4 million. This year, a positive 1.5 million. So yeah, my whole team back here is grinning ear to ear, as they should be. You all know this financial recovery hasn't come without some heartache and pain. We've laid off more than 200 employees. We've had to close services like our skilled nursing facility and cut back on a lot of different areas. We've had to decrease the number of elective outpatient Medi-Cal surgeries and procedures we can perform. And now, we're confronting SB 525. So that hasn't been factored into the budget because, again, nobody in their wildest nightmares could imagine that it would have become law. It doesn't go into effect, again, until June 1st, 2024. But again, that's right around the corner, and we're going to have to start preparing for that now. So just when we sort of breathe a sigh of relief, we now have to take a deep breath again and figure out what we're going to do. And we have no choice. We have to figure out because we have to continue to provide safe, high-quality care for this community, and we're not going to let you down. And so that's probably going to mean that we're going to have to make other hard decisions. We'll continue to advocate strongly to the state, but we really can't depend on them. We can't count on them because so often we're left on our own. So, all right, so those were the questions that were posed to me in advance, and so a couple that came in this morning. Explanation of last year's shortfall of almost 80 million. What was that attributed to, and what steps are in place to get financially better? I don't think the dust is entirely settled yet on this last fiscal year that ended June 30, 2023. We are finalizing our annual audit with Moss Adams, so I haven't seen the final results. I do not believe it's an $80 million shortfall by any means. That could be comparing budget to actual results, although we did budget for an operating loss this last year, but I think it ended up being better than maybe what we were anticipating. Definitely the two major areas that were impacting is we spent tens of millions of dollars in contract labor. As I mentioned, we lost $28 million just in the first 3 months of the fiscal year, spending $8 to $10 million a month in contract labor. So I would imagine that by the end of the year, we'd spent over $50 million in contract labor for traveler nurses, and again, did not receive a penny of additional reimbursement. In addition, we continued to pay a lot of overtime and extra shift bonuses to our employed staff, which really drove up our labor costs, and volumes were relatively flat. Not just here at Kaweah, but across the nation. We saw declines in a lot of areas, particularly surgeries and inpatient admissions. We don't know what that's entirely attributable. I don't think patients were afraid still to come to the hospital, but may have been deferring elective procedures and surgeries out of an abundance of caution. So we definitely have come a long way. In fact, we were already making significant progress over the latter part of last fiscal year. In fact, if you go back and you kind of dissect last year into quarters and months, you'll see that the vast majority of our loss was incurred in like the first 7 or 8 months, but the last 4 months of the fiscal year, we actually had positive cash flow, and we're already seeing things turn around as we started weaning ourselves off of that contract labor. Our days cash on hand, that liquidity measure, which means how much cash reserves do you have in the bank to cover your daily operating expenses. That's a number we pay particular attention to. It's one of our bond covenants, meaning if we don't maintain a certain minimum level, then we are considered to be out of compliance. And we were, over the last couple of years, it triggered a covenant requirement that we move $18 million in unrestricted cash reserves into a trust account that could only be accessed by the bondholders in the event that we defaulted on our debt. As of August 31st, that number has risen to 88.3 days, so just barely below that 90-day minimum threshold required by the bondholders, and that does not include yet the $21 million in distressed hospital loan proceeds. So that will get added to that cash number as well, which will increase that number by about another 10 days. So while you get to add it to your liquidity measure, it is not income because it has to be repaid. There is a provision in that bill that allows the state to forgive the loan, but the state has not provided yet the criteria under which they would forgive that loan. So we remain hopeful and will work as hard as we can to be one of those hospitals that has that distressed hospital loan forgiven. What can we do about getting better quality food output? Do we have an executive chef? Um, yes. So I think I spoke to about 5 different patients over the last week. I think only one of them was really complimentary of the food. So I know that continues to be a challenge. When you're an inpatient, I eat in the cafeteria several times a week, and the food I think is great, particularly the demonstration grill where they're making something new every day, and so definitely the cafeteria food when you're a healthy, patient who has lots of choices and no restrictions and everything. The quality of the food can be a lot different than you are as an inpatient, or maybe you're on a low sodium diet, you're on a cardiac diet. But that isn't the case for everybody, and so no matter what you're in the hospital for, you deserve to have quality, hot, tasty food. We have a registered dietitian, Lawrence Headley, who's our director of nutrition and food services. He is a member of our patient experience satisfaction team. I will tell you that he is constantly striving to elevate the quality and satisfaction of the food. We've had an executive chef in the past. We don't right now, but I'll have to get back to you. I don't know if we're actively recruiting for an executive chef at this moment, but I can say that when Chef Fred was here, who is now the owner of, is it Lafayette? I think is the name of the restaurant in Exeter that he owns, and he's the head chef there. And so when Chef Fred was here, I can say I really enjoyed a lot of his culinary designs. But yes, thank you for that feedback. We know we need to do better. What attributes the 1.6 million from FEMA? Is this a one-time thing? So the 1.6 million again is 1/12 of that $19 million claim. And the primary basis of that claim is those extra shift bonuses that we paid during the COVID pandemic. So when staffing was significantly impacted by either nurses leaving the profession, nurses leaving to become travelers, nurses going to other hospitals, that required us to put more strain on our existing workforce. And so we paid tens of millions of dollars in bonuses to our own employed nurses if they'd work extra shifts. We also paid a lot of overtime, and we paid more than $100 million over the pandemic for those traveler nurses. So those are costs that we think were entirely incurred because of the pandemic. And if it had not been for that disaster, that we would not have incurred those expenses. Some of it was funded by the federal government through the CARES Act. So Kaweah did receive approximately $61 million in provider relief funds through the CARES Act, but that was tens of millions of dollars less than the actual cost that we incurred to provide staffing and drugs and respiratory support and all the resources that went into taking care of COVID patients during that time period. So that's the basis of our claim. Again, I would say the majority of hospitals across the country have similarly submitted FEMA claims. We are worried, that with the fires that we had in Maui, the hurricanes, the floods, the wildfires, just the disasters that sadly that our country has incurred over this last year have gone a long way to depleting FEMA's reserves. I do know that the Senate, and hopefully trying to keep the government open, and I'm getting very worried, as I'm sure all of you are, that is not going to happen on September 30th or by September 30th when the federal fiscal year ends. So the Senate passed a bipartisan bill to support a continuing resolution to keep the government open until I think sometime in November, but it also appropriated another $6 billion for FEMA to cover disasters and to replenish its funds. So it's unlikely that the House is going to take up that Senate bill. They appear to be going entirely down their own path, so I'm not certain that there is going to be any additional funds for FEMA. Now, we were first in line, before all those other disasters occurred, but I've heard the head of FEMA talk about having to prioritize, its release of funds given the shortage of funds that it does have. So keep your fingers and your toes and everything else crossed for us. What did Kaweah do with the money from the state, the $21 million? So we haven't received the money yet. And again, it has to be repaid starting 18 months from the time we receive it. And then it has to be fully repaid within 72 months of receiving it. So we have to be very careful how we spend it because it has to be repaid. And so we have to be mindful of that. I think, this budget that our board approved back in June once again provides for full merit pay increases for all of our staff. It does provide for a partial match on our 401k plan. So unfortunately, we're not able to afford a full 100% match as we've done in years past, but we have budgeted for a 50% match, which is about $5 million in this budget. And so we'll probably use those distressed hospital proceeds to help us fund those costs until the revenues, our revenues come in kind of evenly over the 12-month period. But our expenses, like when we do the 401k match, that's all going to happen at once, and it's probably going to happen in January. And so we won't have built up the cash flow yet to fully fund that, so we can use some of these hospital loan proceeds to fund that. So it's really just kind of providing advanced working capital to us until we on our own start continuing to rebuild our cash reserves and put us in a position to start being able to pay that money back in 18 months. So thank you for that question. And that has brought me minutes away from my 1 o'clock deadline. I've answered all the questions that have come in, but Daniel, any come in, or Kelsey, or do we have any that?
Yes, there's
Okay.
one that came in. How many new family medicine resident slots are available this new coming year?
Okay, so we have 7 slots every year, so it's a 3-year residency program. In fact, I was in a lecture yesterday where we had representatives from the Jehovah's Witness Council out of Fresno were at Kaweah providing education and training to our family medicine residents who were learning about bloodless surgery and other approaches to providing important clinical care to the Jehovah's Witness members. It was a fascinating presentation, but I think we had almost all 21 family medicine residents were there. So each year in June, we receive a new class. Each year in June, we graduate the 3rd-year residents. We are hoping to keep as many of those family medicine residents as we can. We know that we have 3 3rd-year residents that want to stay and continue to live and practice in this community, so we're working with them to bring them on board when they graduate in June. There are new programs being developed at both the federal and state level. So graduate medical education has only been funded by the federal government up to this point through the Medicare program. But for the first time, as part of the state's 23-24 budget, they are going to include funding for medical education at the state level. And they largely want to target it to additional primary care physician residencies. So like family medicine, internal medicine, pediatric, OBGYN, We definitely, if there's an opportunity for us to apply for additional residency slots, family medicine would be right up there at the top. I think primary care physicians is where we have some of the greatest shortages in the San Joaquin Valley and certainly here in Tulare County. So yeah, thank you for that great question.
That's it.
That's it. All right, stuck the landing right at 1 o'clock. Again, thank you to all of you that are joining us live today, and for those that might be watching this later through a recording. Thank you for continuing to follow Kaweah Health. Thank you for continuing to support us and be our vocal ambassadors. And thank you for, just for being part of Kaweah and challenging us. I love your questions, but you don't have to wait to the next huddle. You can reach out to me, reach out to Deborah if you have a question in advance of that. We want you to be our most informed group. So thank you for being a part of the Kaweah Health family, and I hope you all have a wonderful weekend, and I guess we'll see you next month. All right, bye-bye.